Okay, so welcome to our journal club. I know always the meeting would be um, looking for new things that happen in Parkinson's. So in the last months, we have been talking about electricity of the brain and how that electricity happens to help people with Parkinson's. So, so basically, I don't know. You want a movie in the beginning or you want a movie in the end? You are the chooser. So let me see. Let's start with this. So talking about deep brain stimulation, electricity in the brain. Always we speak about waves, electroencephalogram from the alpha. The alpha, like remember, like an animal, the alpha is the dominant, like the alpha wolf, the dominant in the group. The alpha is an important electricity waves that when we're awake. Talking about EEG. But talking in the sleep or medication, we talk about beta, and the slower the frequency, we go from delta and finally theta. In Parkinson, we see the stimulation, we getting the beta activity. Now is the way we do it now. I love to do deep brain stimulation. And now in the past, we need to play around with all the contacts, but now we have the beta activity. Medtronic has been, and there's a big improvement we get. They can tell us this is your beta activity, and we got to the morning. But in the past, we talk about different other waves. We talk about the speech. There was some frequency. Today we talk about another stimulation of the brain and really like some stimulation without being so invasive. So that's like a whole topic in this journal. It's talking about more and more about another stimulation of the brain without going to be invasive, without going to deep brain stimulation. So let's start. Thank you for coming. I know you just had lunch. Try not to fall asleep. You fall asleep. I'm okay with that. I just jealous not to have the siesta like really have it, but it's fine. Okay, so tomorrow was asking me about me. So this is my best half. We're in Venice, right? And it's our third anniversary. So okay, we enjoy that very much. Okay, so this is the movie. We're going to start with the movie a little bit, and then because it's too long, I'm not going to go the whole movie because otherwise, he just watched the movie, he's going to sleep as well. So let me see if that works.
This video shows a guidance through core clinical features, supportive motor and non-motor features, as well as MRI features of the Movement Disorder Society criteria for the diagnosis of multiple system atrophy. The video is initiated by an overview of
This video is very nice. How is that nice? This is you see this feature, the fortune of feature. So we can so alternate function, people can have like orthostatic activation, increased swelling, or having burnout, having the night increase. So
core clinical features of MSA. This video shows an increased urine post-void urinary residual volume in a patient with clinically established MSAC, measured with a dedicated bladder ultrasound device. In case no ultrasound device is available, Urine post-void residual volume can be assessed with in and out catheterization.
So we have to see the point of the volume. We have to see the bladder and they see what the body places in the urine. That's usually the point. So talking about the difference between Parkinson's, let's say we can even run out stimulants. Cancer wasn't really something like that, but it's getting better. At the point that my political to vote up, you're working now as a stimulants. So how it's doing if somebody have Parkinson's, let me say. So we do the stimulants, different parts of the skin, goes to the neck, and a couple of thousands in the lower cervix. Something more proximal versus something proximal stimulants. So when it's positive, that's in the brain, in the skin of the neck. When it's more distal, is more safe. And you think about it, Parkinson's is very like more central, which is right. Later in time you have it. Versus the negative side you have which you do not like this. You have to control the bladder, but then you have to control the blood pressure, then there's time to be swelling. So it's something we're getting what we are now and we offer now. We start with the market,
Orthostatic hypotension as evidenced by standing test. Blood pressure and heart rate measures are taken after 5 minutes laying supine and after 3 minutes of active standing.
Something that well in the medical system is using the blood pressure. The medical orthostatic, I mean, the blood pressure can drop and which is doing blood like one is for the house. The master within the brain and the pump is the heart. That's one level. We see that the position has to be increasing the master, which is the brain, and you have receptors in the neck that cognitive part said, okay, you have to pump to keep the master pump. And we should do this like you have to pay out, so you have to very high level. You don't have the pump, you have to take a shower and you can do it. So the brain is not happy with this. And when you stand up, you have more tendency to go down. So for many of us, we were talking about this problem. Oh, this mechanism works very well. But in systematic people, something like patient, focusing on the two parts, people are doing DC or 90,000. Usually there's a lot of 20. And the heart rate is still the same. Usually, what happens if the blood pressure goes down? People can say the heart rate 25, and have a good. So these are these ways. And this is a fellow in the Venezuelan Society.
Ratio of change in heart rate and systolic blood pressure below 0.5 suggests a neurogenic cause of orthostatic hypotension. Another way to capture neurogenic orthostatic hypotension is using the head-up tilt test. This video shows a progressive blood pressure fall of more than 20 mm Hg systolic and 10 mm Hg diastolic within 3 minutes upon head-up tilt without compensatory heart.
So basically, you see how they elevate the head of the bed, and that's the key thing. Just increasing, I tell you about the 2-3 house, right? So I tell you about it. So with that, you see just move the head up.
Rate increase, consistent with a neurogenic orthostatic hypotension in a patient with clinically established MSAC. Prolonging orthostatic challenge to 10 minutes leads to further decrease of blood pressure without heart rate increase. The video on the left shows MDS-UPDRS Part 3 assessment in a patient with clinically established MSAP when drug naive.
So this is the very important part about the response to dopamine. So I always explain Parkinson's versus Parkinsonism. The Parkinsonism MSA. So this is very important. You want to see these patients, what they do in the dopamine challenge. Many people don't understand why I do the dopamine challenge, why you have to give the medication here. And you see this guy, they before and after dopamine, there is no significant change with dopamine. So that means Parkinsonism.
Video on the right shows the same patient a month later on 100 milligram daily levodopa, demonstrating poor levodopa responsiveness. Total MDS-UPDRS Part 3 scores on the left video equals 54, and then the right video equals 49, indicating less than 30% improvement.
It's almost no difference between the red and the black. It's just the clothes, but definitely there's no difference in making. This is what this guy is doing is we call the food test. Most of the time not doing it in the clinic because people have a very bad balance. And you can see in the always asking to walk, we're looking for the stoop posture, we're looking as well for the arm swing. And definitely there is not much difference between the two places.
Clinical features on cerebellar syndrome are demonstrated in this video. Segment 1 shows a gait ataxia in a patient with clinically established MSAC who takes multiple steps on the side to keep his balance and is unable to perform tandem gait.
So this is clear multisystem atrophy type C. The C for cerebellum meaning the main issue is the balance. So no much of the tremors, it just he's walking like he's drunk because he has no balance. The cerebellum is the one to take care of the balance. So that's MSAC.
Segment 2 demonstrates limb ataxia in the same patient with bilateral dysmetria during finger-nose testing.
What which is the end one is this patient look like he had a stroke in the cerebellum. So dysmetria, when you finger to nose, you have to hit the target. But then you somebody's drunk or have problem with the cerebellum, they go to the target and they pass. That we call dysmetria. They don't measure very well. So I go to the target, my vision is okay, I have to be able to do that. But in this case, to see how he meets the target. You see that?
Segment 3 demonstrates cerebellar dysarthria with slurred and slow speech sustained.
Now we're talking about the speech. So this patient sound like they had a lot of alcohol, like drunk without drinking. So that's we call cerebellar dysarthria, or we call scanning speech. So listen to this.
Phonation and repeated phonation are particularly difficult.
Massachusetts General Hospital. Mama, 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 mama. La, 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 la.
This part shows different oculomotor features in patients with clinically probable MSAC, including.
Okay, well, to stop there here, there's the full video, and a part of the video could be a little looking at the progression, so they can see a little disruptive to see how the progression could be, and I just don't want to go there. Let me just finish this. If we have the first snore and then after, that's good. What a good. Okay, so let's continue with the presentation. Okay, here you are. We have some of this is in Venice sunset. So yeah, and I'm done. Okay, so we're talking about the stimulation, and again, in the part and the end we can continue the video. But I think we now to go to the full journal. I try to focus more with the last journal in June, tell us about different things in Parkinson's. Always I include some other movement disorders, but let's talk about the waves in the brain. In this particular, there are another ways to stimulate the brain in Parkinson's, so we're getting some benefits. So this will be part of the future. Without getting very invasive with neurosurgery, we can stimulate the brain and producing some benefits. So this is the transcranial temporal interference stimulation. It's called TIS. So this is one of the main of the hot topics in the journal. We talk about the waves. There is non-invasive deep brain stimulation. So we talk about the conventional continuous surgery versus something that is transcranial. So we try to stimulate these brain areas, these deep brain areas that are localized, what we call the basic ganglia. The thalamus, we call the caudate, the putamen, the substantia nigra is lower than that. So basically, we are looking a lot of application only for Parkinson's, but in the psychiatry conditions and movement disorders. So we're very excited as well for using for essential tremor. Many people cannot go to surgery, or some people have a pacemaker, so many people come to get evaluation for high frequency ultrasound, guided by MRI, but if they have a pacemaker or have the leads not compatible with MRI, then we say no. Yesterday, somebody coming and said, no, there's a problem because you have a pacemaker, so I cannot go for transcranial. We cannot do brain stimulation, or I cannot do the high frequency ultrasound. And then I looked at the card and said, no, you can have MRI with that. So it's important to look at that. And if for some reason any of you need to have a pacemaker which is MRI compatible, that way in the future you need a different type of therapy, we can pursue with that. It's very important. Okay, so in the past we have been talking about transmagnetic stimulation. We have been talking about transcranial electrical stimulation. There is some different types of stimulation. And finally, we're getting a little more in the top of this in the journal. So, and actually it's not as is as well for diagnosis. Before we went to deep brain stimulation, we can go to this kind of non-invasive therapies. And I want to show you some studies along this talk about how there is a big hope with this new technology. So we're looking for the transcranial focus ultrasound that again, this could be not only for treatment, depends on the frequency, we can do just stimulation or we can do ablation. So this is, again, I have to talk enough about how important is this advance in movement disorders, because it's not invasive. We can do neuromodulation, meaning we change the electricity of the brain. And with this kind of therapies, like you go from a therapy for massage therapy, you go to your transcranial or your FSU or these non-invasive techniques, and you can get better with your Parkinson's. And then it will be a guidance for more invasive. So these studies that are presented in the journal for Lanus, and they were applying in the subthalamic nucleus. The subthalamic nucleus is a target that we use as well in deep brain stimulation. So basically, we're stimulating the same areas without getting to electrode in your brain, and do it through your skull, and have been seen and have been proven to be effective. So there is another different other studies showing the same. So basically, we're looking about the frequency. In this case was 130 hertz. That means like 130 pulse in a second. So that's high frequency. So there's a new technique for cleaning in Parkinson. It's a potential. We're looking inside deep brain stimulation. So, and there is again, in this say this is something is not exclusive. And in the future, we can use as preliminary or complement to invasive DBS. So non-invasive versus invasive. Instead to be exclusive, one comes first, and then we need the second one. And actually do well with non-invasive, probably invasive is more permanent to be for you. So besides Parkinson's disease, we're very excited to use in psychiatric conditions. Even deep brain stimulation in the past, when I was a trainer, we're using for possessive compulsive behaviors, still using for depression. So it's not only for Parkinson's, have an application for many other things, and even using for seizures as well. So this is a new, a very novel potential approach of treatment for being non-invasive deep brain stimulation. So we call DBS, in the past we're thinking about the surgery, but it's invasive, and we saw a non-invasive DBS, standing for deep brain stimulation. Okay, so you know, the journal continue with the same thing. They do like to look for non-invasive, it's the same that we just talked right now, but it's an article in this journal about the same thing. Non-invasive temporal interference stimulation in the subthalamic nucleus. The subthalamic nucleus is the main target we use as well for the invasive deep brain stimulation. So we, as you see, we are very excited. This is the society is very exciting about these techniques. So this technique has a potential to be effective to modulate the subthalamic nucleus and reduce the beta. So this is, we're talking again about the electricity of the brain. So the beta activity in people like Parkinson's, like you, is one to suppress. And actually, we're looking now with the new technology for DBS, again, we're looking for the beta activity. We're learning more and more. In the past, I was spending many hours of trying to localize what the best contact in deep brain stimulation, but now with that electricity, actually what happens in the future, the deep brain stimulation give you the feedback, and actually artificial intelligence in the future, the DBS will be doing its own programming. So that we're looking at. Just less than 1 month ago, Medtronic launched the NeuroSense and how you can do adaptive deep brain stimulation. It's the new technology. So I think the other company is looking, as I said, the good and the bad, but I think this is a very good advance in deep brain stimulation. Look again, another topic. The article is all about it. People is very excited, and so it looks repetitive. But again, the transcranial temporal interference stimulation is there. So beside the substantial area of the subthalamic nucleus, now it's in the right globus pallidus. So that's for Parkinson's. And now we're looking for essential tremor. We can do the same, but look at different targets in the thalamus. So sorry to look at that like too technical, but this is what is hot now in Parkinson's. And so basically, there is a pilot studies that went that showing this type of stimulation is a non-invasive approach for the brain stimulation. Okay. Now, remember we had before a question about how effective is the magnetic guided focus ultrasound motorbits. We talk about high frequency ultrasound, and we talk about the ablation. So basically, in previous talks, we talked in study in Denmark that showing that with this we can have problem with the gait, with the speech, but with this we got to see the main thing. Again, I don't want to go to the whole article, but it sounds that how effective is this is studied good enough with years. You see that in the 5 years or so, this technique start not being as good as. The contrary with deep brain stimulation, usually works for years and years, but it's an ablation. So, okay, so we continue with all the effects of these stimulations, and again, this is the point here. It is that Then this is the phrase. Again, I want to read the whole thing that this is our results suggest a decline, a high effective over time across 5 years. So that's the main thing in this article, that particular phrase. So it's not as effective or declining in 5 years. Okay. We go to a different topic now. So remember we're talking about everything that we're thinking about Parkinson's, and in particular, if you are Jewish and you have the LRRK2 mutation, there's a with type of Parkinson's. But we're looking now in this article that not everything is like the typical Parkinson's. There have been some questions about if it's really associated with alpha-synuclein. The alpha-synuclein, again, is the protein, the misfold protein that produces Parkinson's, or Sunday Parkinson's. So there's some question about this particular challenge and little about the definition about that particular pathology. So this is the neuropathology about getting Parkinson's disease. So to have Parkinson's disease, we have to go to the neuropathology. You have to have both in the substantia nigra, the alpha-synuclein, and to both accumulation of the Lewy bodies. Remember, the Lewy bodies and the alpha-synuclein are the particular, we call pathognomonic. That means that is the typical presentation in the tissue of Parkinson's. We're talking about the alpha-synuclein localized and the substantia nigra versus localized in the peripheral nervous system. That's an example. Parkinson's is in the central nervous system, mainly substantia nigra. And now, in this particular variation for Parkinson's, that challenge because it's not present as the typical Parkinson's. Oh, look at that. Now we're in Florence, and it's close to the Ponto Vecchio, right? So that's the only bridge that was not bombarded by the Germans when they could do Florence. So our that bridge is not, it's opposite. This is actually the Ponto Vecchio is the other side. This is just the regular, just the sunset went down. Unfortunately, I cannot change the sunset to the north side. So in the other side, there was the Ponto Vecchio that actually you have is the only bridge that you have actually buildings on top of the bridge. And there's that street they sell a lot of gold. It's very busy street. But it was a beautiful sunset, and you know I love sunset. That's my hobby. And thank you. Some of you have been sending sunset. I have so actually one of my patients, and he was in Africa. He was kind enough to do actually he has a special treatment with iron, and I have that picture there. So I have several pictures in my office. I have a patient that has from Lakeland, and she has a different thing. It's actually she painted my former dog that is in my office. So I appreciate what you send me. Not that you need to do it, but I appreciate it.
And we use send some.
Remember, you can get in the portal, or we can do something. We can talk about that.
Okay.
Thank you. So whenever you have any traveling or something like that, make pictures for sunset, and we can actually in the end of the year we do like a tournament or something. We can see what the best sunsets.
Okay.
Yes, so something like that. Yes. And actually, my spot I like to go in Sarasota is to go to Birki. I spend hours and hours there. It's about like that. Anna Maria as well is very good. So there is a lot of places. So enjoy that. We're in paradise. So enjoy before we had the last night we have a very nice storm, right? And actually in my neighborhood we found the power cell, and it was very good. It was very noisy. We had the lack of power for a while. Okay, so let's move to a different topic in this journal. And again, is the official journal of the International Mood Disorder. That actually the headquarters is in Milwaukee. I did my PGY work in Milwaukee. Very nice to know there. Okay, so let's look for another long-term stability of spatial distribution and peak dynamics of the subthalamic beta power and Parkinson's disease. So this is again the hot topic, and this is more talking about deep brain stimulation again. So basically, this seems to be a biomarker. The way we go for stimulation, and we have to with medications, we see with the brain cells, we look when the beta activity is more there, we have to suppress that, and that's where we go to the stimulate. So I think the rest of the DBS were here, they were very excited. So the sultolami beta oscillations are a biomarker for bradykinesia. So if you hit it, there's activity there in the brain, and it's again not even deep brain stimulation with the other technique. We can actually decrease the bradykinesia, we stimulate the area, we can decrease the rigidity. So this is as well, this activity is now have a feedback in those electrodes, and then in the future, just the DBS depends on the activity can actually feed by itself. So basically, like you have it in automatic mode in the car, in a cruise, the more you go up or down, you have it right. So that's what the future can do there. So that's the activity. This part basically, the main place in this part is that this optimized DBS. So the beta power is stable and it's part of the work. Every day now, more benefit. You have electricity last night, so they have the electricity, but you have electricity. So the delta gamma sultolamic stimulation for verbal fluency. In the last problem we talked about the stimulation for visual, we talked about the verbal. So they are linking as well. Most of the time we talk about thermals, but we have the vision. You see, the part is we're talking about is an issue with the cortical stimulation and versus the visual, and people have tracing it. So we can usually understand that this is a fine thing that we can probably. There you are. Electricity. The way it's helping that is on the side. So basically, one important simulation for this you know, the business can perceive with. So one of the things we do from the screen now, and somebody has found the history, is looking for this memory disability. That now we have the electricity. We talked about this and then there's a link with the cortex and the so again, I completed something that I want to tell you the main phrase right here. This finding suggests that motor cortex dissimulation and postoperative dysfunction might be linked by common the way the Parkinson's okay. More about it. So the visual model network dynamics associated with racing. This is actually very interesting now we're talking about this. When you see people trying to particular narrow space, they get this. Sometimes I just smart. We can with the laser include in the water. So for people that have this episode of having freezing in the apartment, they can do like a lines, the blue lines, like a silver. You can get play the step in those they can play down with it. You see the more activity and like that. So the physics of the gate is from the gate is already that especially when you guys see that people try to get like tools to get like stop, go to the door, they can stop. So we are trying to understand a little more how the networks in the brain is happening, what is happening. So we look basically in the visual, in the gate. So the more we understand this, with the impact of the we can help that, but now we just use visual cues. So looking at basically the visual, the desk clutter in your house. That is not too much of the narrow space. If you can do the visual in place, the space too narrow, and you can do some visual cues. When you start the freezing, that's why we use the laser into a block. So we're looking at how the vision is going to the gate and the networks affecting the gate environment. A little bit, I mean, what is the- and this one is that's it. This is very close. And actually, I did not see this one, but I didn't see. If you can see the composition of the you see the grid. Yeah, you see the guide. Talking about the colors, actually. Now we got the colors in the retina. The retina is on my back to my mind in the Parkinson's. The more the Parkinson's, the more the retina became more colored. So you see all the colors. If you see somebody with more Parkinson's, but the color is still actually. When I look at the retina for the stop the decision it's percent, but with some elasticity. Remember the eyes are the limit of the color, right? It's about optic this color, if I could do it, it's about the color. So the more this is in UK, that the longer you have practices, the color will be better. I know what you said about that. Let's go. But actually, I like how you move like this. Actually, that's the guy. So, it's a confusing. The optic is the pattern, the next color. Isn't associated with Parkinson's disease, maybe from with disease right? The longer Parkinson's, the less topic here. This is a new medication. You know what a medication is in research? They place letters. We don't know what the compound. That's between the pharmaceutical. But this is a trial that we're hoping is going to come soon because we don't have too many medications for dyskinesias. If people have problem with amantadine, so this is for dopamine-induced dyskinesia. So this seems to be very promising. So this is in this article. We don't know exactly where it's going, but I would hope that will be there. So I just tell you that we're soon hopefully have a new medication for dyskinesia. The only thing we have for dyskinesia now is amantadine, or decrease the dose of taking medications. So this is the deal, and that's why our philosophy or try not to start dopamine right away. In fact, okay? The younger you start with dopamine, the higher dose you use dopamine, you can have motor fluctuations, and at some point you start having dyskinesia. You are a female, and you have more risk to have dyskinesia. There's a study that they're supposed to be the opposite, but unfortunately, that you have the choice what to your food. I don't know, you know. Basically, they try to do a study with levodopa and carbidopa and entacapone, we call it staligo, try to decrease dyskinesia, but actually study showed the opposite. Actually, entacapone produces more dyskinesias than that, and in women we say no. So the main thing to take from this is the longer, the higher amount you take for dopamine, the dopamine start working less and they increase the dose and start taking more and more people start dyskinesia, which could be a couple, could be pick of the dose dyskinesias or could be wearing off dyskinesias. So the levodopa induced dyskinesias and Parkinson's disease is associated with false transmitter. That means because the neurotransmitter is there too much, but the receptors are not definitely this misfiring. And basically, they see that it's a release of serotonin. So there's a different pathway. So I see this medication that we're looking is about looking at pathway that serotonin, the 5-HT receptors. on neurons. So we're looking, and this is the first medication in class, that looking for the serotonin pathway to decrease dopamine-induced dyskinesia. So remember the name, the NLX112. Why is it there? I don't know, something that like the serotonin in the receptors, HD5. So that's the results. Again, I want to read the whole thing, but I'll tell you the results support full clinical investigation of this drug for the treatment of Parkinson's disease level of induced dyskinesia. So we hope that we can do this. And just almost a week ago, I had the opportunity to have a dinner with Dr. Hauser. Remember Dr. Hauser, the one that described Gregson, and he talked about now there is a pump. There's a pump with an amantadine and apomorphine is another one. So this is to improve the off time in Parkinson's. So somebody has no improvement, we have another tool, and it's here. And so we can actually, I want to bring Dr. I want to coordinate with you and Dr. Hauser probably for next one or something. We're looking for I don't know they contact you, but the
yes.
rep.
I think on August 21st.
Yes, it is. Yes, or yes, yes, August 21st. I want to invite you to listen to Dr. Hauser. We are very proud to have Dr. Hauser. He is one of the main researchers in Florida, and he has been in many studies, and they got the correction, and now he got to this pump as well. So he's part of the Neuro Challenge, which I participate as well. He's part of the on board of the medical Neuro Challenge, but he's very good, very well known in the movement disorder as a researcher. So I invite you to come August 21st. He will be here in person. He is very good researcher, and we appreciate his help, and they're willing to come to the Parkinson's place. I invite him personally, and he will come. So I think he's confirmed himself. I'm very pleased.
We're excited.
And now I will be here like you. I want to take a little nap. Okay, so this is another hot topic, and actually a painful topic about the pain, because somebody proposed that the pain can produce Parkinson's. So we think it is more Parkinson's producing pain, pain producing Parkinson's. So that's the conclusion. So what is the chicken or the egg? We know chronic pain is always associated with Parkinson's. You think about it too much, stress in the joints, or another different reason for Parkinson's, you have to make more effort to walk. There will more strain in your joints and more in your back. So the conclusion is more that is not the reason that I have Parkinson's. Parkinson's producing chronic pain. In conclusion, is even though some studies show that the good potential between chronic pain and producing Parkinson's is the opposite. Parkinson's definitely you are more risk than high chronic pain. Here we are. This is the thing that the cartoons are. I always said when you go to Venice, go where you can, because in the cartoon just go on this and you see the two people sleeping against the other. So that's we like to enjoy from this. So they go on the land. So that's all for me today. No more pictures for Parkinson's of the Venice next time. So I open for questions now. Any questions? Yes.
Is the non-invasive targeted ultrasound, is that something local or is that?
The non-invasive is just in the journal now. We don't have that now. This is something again, that's fresh. This is like a fresh bread, right? It's there. We smell it, but you cannot eat it. It's there. You see what the bakery said, no, it's not ready for you. It's in the oven. It's in the oven, but you can smell it, but you can not eat it.
So is it provided anywhere yet?
No, we just get this. Again, we have to look at those articles where they're doing the research. So we have the regular focus ultrasound just for the invasive for the ablation in Tampa General. We have the Boca Raton Celebration, and Miami. We don't have it here, but that's invasive. And we see in the study showed that went off in 5 years. and it's an ablation. The one way like in war, you get to the target, you kill the military, but you are a little off, you kill the civilians, meaning you can produce it with the speech or the gate. But the ones are in the oven. You smell it, but I cannot give the right to you. But, yeah. Yes, sir.
We were aware that Harvard has used nicotine to help in Parkinson's.
The question is, we are aware about the nicotine use in Parkinson's. Yes, we are aware of that, and we always, well, you know, where we have this topic sometimes, like 2 years ago, I talk about the good about the nicotine and the caffeine. We know for years that nicotine can prevent you to have Parkinson's, but you already have Parkinson's. We don't promote you to smoke. The problem with the nicotine is how you use it. You use it like in combustion that affects your lungs, but nicotine is a drug, like caffeine. The problem is the amount. This the same we talk about medical marijuana, and it's the way you use it. And nicotine definitely, many studies have been used. The nicotine not only for Parkinson's, for cognition, for energy, for fatigue. Yes, sir. I'm aware. But thank you for that. But thank you for making me aware. Anybody else? Questions? Still awake? Carbidopa leopa? What do you mean? So the question is about the carbidopa leopa side effects. So that we just talked about the topic about using too much. You can have the levodopa part, you can have the skin disease. The carbidopa, what to the history is just to prevent nausea. So basically, the carbidopa leopa by itself sometimes don't have enough of the carbidopa and people have nausea. So the main side effect from the carbidopa that is not enough, and the levodopa is initially is not for everybody. So it's for the real Parkinson's, as you see, people do better. But for people with MSA or Parkinson's, the proof actually is not good, and sometimes actually have significant side effects. And the more you use levodopa, you can have hallucinations. Blood pressure can be down. So I always say the levodopa in my cocktail. I would say, you barman, I give you the right cocktail in Parkinson's. In difference with other conditions, I have to give the combination because the levodopa, as we talk, you use too much, you get drunk. This can easy. Or can have you hallucinations, or can make your blood pressure low. So we try to, first of all, not start it too soon, and second, not to use it too much to produce this side effect. So that's why our philosophy is somebody have Parkinson's, very early start the cherry dark cocktail, which is an MLB inhibitor or recycling. Many of you know I asked you to come 6 weeks after that. Then when you get to the age to have the alcohol, that means you really need the dopamine. I place the alcohol in that cocktail is the levodopa. And sometimes you start having difficulty with tremors, then I can use something for tremor issues. The best tremor is a dopamine agonist, like pramiprazole. And then that's like the pineapple in that cocktail. And then you have an issue with complications, I give a COM inhibitor to prolong the carbidopa, or you have complications with this kinesis. I place another ingredient, which is the amantadine. Amantadine is to decrease the dyskinesia. So yes, there's a lot of side effects. So this is a drug. It's important to, and the same time, it's like the money in Parkinson's. You can produce your dopamine when you do exercise. By using too much, too fast, you're feeling great. Many neurologists start one, the second year 2, 3, 4, and get loaded with a lot of dopamine. In the beginning, you feel well. Or there, I see somebody came with 26 tablets of carbidopa, and once like this, they do it too much. So the answer is yes, too many side effects. Any other questions? Okay, thank you for being awake. Yes, sir.
Yes, went over the.
Any comments about the Crexon? Yes. Yes. So the question about the Crexon is recommended. So thank you for the question. And I, Dr. Gonzalez, approved the measure. I don't have any interest in Crexon, but I very happy when there's this medication. And that question I want to ask you, Dr. Hauser. He wants to speak a different. But again, the Crexon is talking about carbidopa. I always give this example. Probably many of you hear this already, but I want to repeat this because that's the way I feel. That's the best way to explain. The cinnamon of carbidopa is like the iPhone 1. iPhone is an iPhone. If I use an iPhone 1, you can the iOS, then you can speak with that on an old phone, right? That's the iPhone 1. The iPhone 10, more technology, carbidopa leopa, the same, but more technology, was the right target, the menu you use, and it's very difficult for me now to consider right target, even the same company, to Crexon. Crexon will be, again, it's an iPhone, but 16 more technology. There is a polymer, there is immediate release and extended release, and there will be very slow initially, immediate release like this. The polymer make it stick more in your stomach, and the delivery system is very slow and very nice, very graduated, like you have at home. And they will be give you 1 or 2 hours and a half more on time. So that's the advantage. If you are taking carbidopa, the immediate release is straight, less than 500 milligrams, meaning less than 5 tablets per day. Most of you use 3 or 4. Then I can use Crexon 280 milligrams twice a day. So the advantage is you don't have to worry about your lunch. You just take it in the morning, or you take it at night when you go to bed, and that's it. You don't have to worry around it, right? So what time to eat? I miss it. Many people being busy, working, they forget taking medication. It's very difficult for compliance. So that's the advantage. And you have to follow this rule with the proteins. But I found out my ratio is 7-3. 7 people do very well, 3 not. Some people that do not well with Crexon, I found number 1, they're from proprietary, and number 2, they have some sort of gastroparesis, meaning the stomach moves very slow. Remember, Parkinson's can produce constipation, so people have problem with the stomach not emptying well. So those people, the Crexon will not work very well. It's like you place a turtle in a highway, right? It's very slow, and just when you away, oh, the girl is stuck, and that don't work. So I hit 7 and 3, and the beginning was so exciting, and they were giving a significant amount of the sample. Right now, not providing the sample as much, but I sent it to a special pharmacy, and they can give you coupons. So you start having some fluctuations again, it will be an issue now. I tell you the truth, the main issue with the Crexon for me is being authorized from the insurance. Because this is the same, and now I said to my patient about, we have a very good medication for headaches. But the new headaches medication, you transfer the headaches for you to me. It could not be a headache for me to get all the paperwork to be approved. And paperwork, you cannot believe, have like these tons and tons of paperwork, and now they have to get to those paperwork, and then it's a pain, because sometimes I give the sample works very nicely, but now insurance don't approve it and will be very expensive. So that's a problem. Also benefit. But I love the medication. I love it. And again, I don't have any stocks in our company. It's very nice. Any other questions? Yes, sir. Let's start. Yeah, I could be a good thing for buying. Okay, any other questions?
Right here.
With the Crexon, can you, if you want to introduce a regular traditional levodopa, carbidopa leather with the double tablet with that, if you feel you need more?
So the question is about you on Crexon already. You can, this for the people for the Zoom, if you're taking Crexon already, you can add or introduce the regular cardiopa. The answer is yes. Ideally, is you have to stick in only one as the advantage, but if you think that you need a little extra, that means probably increase the Crexon, but it's nothing wrong. You hear from the company or you hear from researchers, they say, no, you have to stick only to Crexon, but again, it's okay. You probably don't need the extra every day, right? So sometimes we have the fluctuations, so depends on the day, you can use a regular cardiopa, or we can, in addition, we can use, some people don't suffer for an issue with raw pressure. Some people have that, and don't say anything about your husband because it's just, but some people cannot be a good idea to use Imbrilla. Imbrilla's levodopa, but it's a spray. Okay, so actually can work like this. You don't have problem with autonomic dysfunction. That could be a rescue therapy. Actually, you have some people have. I just mentioned about the gastroparesis. Some people not tolerate, and one patient don't tolerate the cardiopa, so have the spray. The spray could be an addition to Crexon, but the problem is you have autonomic dysfunction, hypertension will be nowhere here. But you can use the regular cardiopa levodopa. So the answer is yes. So, Thank you for your question. Any other questions? Yes, sir.
Start out.
The question is if I always start with carbidopa lopa, so my answer is no, I don't always start carbidopa lopa. Our philosophy is, or my philosophy always, train your sound. You see different neurology, different schools. Some people just start carbidopa lopa, and you know, get better, and start hitting, and increase carbidopa very fast. Our philosophy is the opposite, actually. I tried just because you just talked about the drug-induced dyskinesias. The sooner you start carbidopa lopa, the higher dose you use it, or the younger you start carbidopa lopa, the more likely you will develop motor fluctuation. So I usually, if you have, and I like to diagnose people very early Parkinson's. So I see some guys having a little decrease on swing. I don't have the rigidity of the tremors. The answer is no. I give you exercise, and I start with the cherry, that cocktail with recycling. And again, later in time, you just know 60 by 70 to 80. It's okay. You can have your carbidopa lopa. But you have a little tremor only, and then the recycling is working, and then you have tremors, then I start dopamine agonist. And then on time you say, oh, really, you're not getting any better, or you have intolerance to medication, and introduce carbidopa lopa. And I always recommend exercise, and then they would that, that's the standard of care. But that's the problem with carbidopa lopa. The higher, the sooner you use it, or the higher dose you use, you're in trouble. That's like the money. I always make an example, it's the carbidopa lopa is the money in Parkinson's. It's like you get 60 years, you have your 401k, it's I have a lot of money, let's go to Venice, let's go now to France, and then after 6 months, I have nothing, right? So they're saying, so I have to spend that money wisely, so I cannot use it too much. So that's will be there. That will answer your question. Your question, you have a question, or you have a right, no, you good. Okay, you good. Anybody else? Okay, thank you for coming, and again, August is
21st.
August 21st, house here.
Tentative date.
July, and would be, you asked me about the topic. We do the same, we do review articles or something new, and that's what we're very excited to see Dr. Hauser, and
Yes.
our goal is to get more people that are getting present. The other person I would like to bring is Dr. Fernando Pagani. He was my mentor in Georgetown.
Okay.
So we try to get, we can get it. Once we can dispose of something, we want to, we're interested.
Great.
Okay,
Thank you.
very good. Okay, thank you, Martin.